Right, welcome and thank you everyone for attending the September 4th Thursday's Lunch and Learn. Please remember to hold your questions until the end of the presentation. We will accept questions by phone as well as via chat. In fact, I'm going to now mute the phone if there are no questions for any callers. Okay.
All callers are muted and they can unmute themselves.
So I would now like to introduce our speaker, Dr. Ann Kushwaha with Houston Breast Imaging. She is the director of the Memorial Hermann Southwest Breast Center, and Dr. Kushwaha will be presenting information about identifying high-risk breast cancer patients in your practice.
Hi, good afternoon. I'm glad to be here, and hopefully this topic will appeal and provide some knowledge to you in your breast cancer practice. So my objectives of this talk are first, who is a high-risk patient? How do you identify them? What our clinic did to identify them better. Then once you identify them, what do you do with that? What do you do with them once you identify them? I'm going to discuss kind of our process mapping, our training of employees. I'm going to talk about genetic testing, issues with genetic testing, and then finally the results of our program, which has been about a year and a half we've been doing this. First of all, what is a high-risk patient? Mainly they're under two categories. Patients that have genetic mutations. The main mutations that we're going to talk about are hereditary breast and ovarian cancer syndrome, which are patients that are increased risk for breast, ovarian, pancreatic, and prostate cancer. These are the classic BRCA1, BRCA2 mutations, as well as mutations detected with BART testing. The other big category that we're trying to capture in doing this is the patients that are BRCA negative, but still have a very, very strong family history of breast cancer, or even more commonly, patients that have a strong family history and just can't get tested for their BRCA, choose not to, or don't have access to the people that needed to be tested are not available either out of the country or have passed on. The main thing that you need to use to, the guideline is that if you have a greater than 20% lifetime risk of breast cancer, these are high-risk patients as well. And the best model, computer model, that has been researched and studied is the Tyler-Cuzick model, which was founded out of Harvard University. And that is the recommended model to use when you're trying to evaluate these patients for high risk in regard to whether they should receive screening MRIs. There's other programs, people might have heard of BRCA Pro, the Gale model and stuff, but Tyler-Cuzick is the one that was used and is recommended for some of the questions in radiology. So I'm not going to do a big talk on the genetics of this. You guys have had other talks from Breast Health Collaborative, but basically the hereditary breast and ovarian cancer syndrome is a deletion of one of the tumor suppressor genes in the patient, which means that the patient's body really can't fight off cancer cells as well as a patient without this gene mutation. And statistics are, if there is a BRCA gene, if the patient's BRCA positive for genetic testing, they have a lifetime breast cancer risk of up to 87%. They have a risk of breast cancer by age 50 of 50%. And the risk of ovarian cancer by age 70 is about 44%. In comparison, the general population risk for breast is just 8%, and ovarian is actually less than 1%. So there is a national comprehensive cancer network that provides guidelines, and we basically use these guidelines for recommendations on genetic testing and high-risk screening, and I'm going to go over them. Next. So just a little history. These were guidelines from 2012, and this is when these are the guidelines we were using and have been using. I will discuss in April of this year, they were upgraded, some significant changes, and I'm going to discuss those changes, but just for the kind of the timeline of how we did this, I'm using these first. And you can see they're pretty complex. I don't even know, hopefully you can read that slide on your computer, but I'm going to just briefly go over them. Basically, genetic counseling is recommended If a patient obviously has a family member with a known mutation, then they insurance and they should be recommended to test. The other indications are if you have a personal history of breast cancer, you have to have one or more of the following. And this is you were diagnosed less than 45 years old, you were diagnosed less than 50, and at this time you had a close relative with breast cancer also diagnosed over 50, plus one other, a relative with ovarian cancer. Or you had two breast primaries in the same woman, and the first had to be diagnosed under 50. Or if you're diagnosed with breast cancer under 60 but are triple negative breast cancer. There's one about limited family history. You're diagnosed under 50 but you were adopted, or you don't have access to your family history. If you were diagnosed any age and you had two blood relatives with breast or ovarian cancer, if you have diagnosed and you have two relatives with pancreatic cancer, if you have any male relative with breast cancer, or if you're Ashkenazi Jewish descent. Those are the recommendations for genetic counseling in 2012. Also, more straightforward one, anyone with a history of ovarian cancer is recommended to be tested. Anyone with male breast cancer is recommended to be tested. And anyone with pancreatic cancer with two or more relatives that have breast, ovarian, or pancreatic should be tested. There's this long paragraph on family history only, which basically states that if you have a first or second degree, which I'll go over what that means on the next slide, and that meets all these criteria, if that person is either can't afford it, has passed away, or is lives in a different country and can't get tested, you could possibly get tested if you still want to know. Also, all the way down to a third degree, if you are a cousin but have an extensive family history on one side, theoretically, it's recommended you can test. Now, in practice, the insurance companies are a little dicey on whether they approve some of that, if I've been told. Just to briefly go over what's first, second, and third degree. If this is the patient with the arrow, a first degree is brother, sister, parents, children. Second degree is grandparents, grandchildren, nieces and nephews, aunts and uncles. And third degree is a first cousin. So anyone in that spectrum counts as a family history towards testing. So if your cousin has breast cancer and your maternal grandmother, that would count for you if they're on the same line. So these are the current NCCN guidelines for if you are high risk, which is a greater than 20% lifetime risk of cancer. These are what is recommended for your screening. And it is a lot different than what the general population is recommended. And that's why we really want to try to capture these patients that come through our breast centers or even our clinic if we're not a radiologist, but any other specialty. First of all, and I'm highlighting that a breast self-examination awareness that's been downgraded is recommended starting at age 18. The science behind that is that really breast self-examination has not proven to decrease mortality and has been shown in studies to increase benign biopsies. So the cancer guidelines now on multiple sites basically they're not telling the doctors to spend time in their office teaching breast self-exam because they don't think it's worth the doctor's time. However, they are saying that the patient and other outreach programs teach these patients and be aware of how to examine your body. And obviously, if there's any change in your body, to see a doctor, see a practitioner, and be seen, especially starting at a very young age with these high-risk patients. The clinical breast exam has been studied and is recommended semi-annually, started at age 25 in these patients. A mammogram and a screening MRI are recommended starting at age 25. Very different from just general population. There's a little asterisk beside that. There's been some studies that are concerned that the BRCA1 patients are more sensitive to radiation. So there's some debate on whether maybe we should start mammograms at age 30 and start the MRIs at 25. So that's a little asterisk on that one. They do recommend discussing risk reduction mastectomy and counseling, including the drip protection it provides, the reconstruction options, and the risk of surgery. they actually recommend getting surgery to take out your ovaries and your fallopian tubes between age 30 and 40, or upon completion of childbearing, as well as individual risk by the patient and family history. For those who do not elect to undergo salpingo-oophorectomy, they say consider, and I'll explain that lower word, transvaginal ultrasound and CA-125s every 6 months starting at age 35, or 5 to 10 years before the lowest age of onset of ovarian cancer in the family. And they also consider chemotherapy prevention options. The reason these have been kind of downgraded to consider is because studies showed in these BRCA patients or high-risk patients that transvaginal ultrasound and CA-125 testing is actually not very good at picking up ovarian cancer early in these patients. And same with the tamoxifen and the raloxifene. These patients tend to be triple negative or ERPR negative patients, and these the tamoxifen and raloxifene are estrogen blockers. So if your tumor is not not estrogen positive, those drugs are probably not going to work so well in these patients. Okay, so now how do you identify these patients coming through your clinic? And the subset is basically our changing forms, as you will see. But we had a discussion with our genetic counselor, a couple of them that we consulted. Myriad Genetics, which is the company that does run the BRCA testing, or just has the ownership right now, or did on the BRCA testing. And they basically came up with basically 7 to 8 what we call red flag questions that you need to know. These are: is there a personal or family history of breast cancer under 50? Is there a personal or family history of ovarian cancer in the family? Is there any male breast cancer anywhere in the family? Are you Ashkenazi Jewish descent? Have there been 2 breast cancers in the same person, or 2 breast cancers on the same side of the family? Has anyone with breast cancer been triple negative? And do you have any pancreatic, and it says associated cancers, which include fallopian tube and ovarian, in the same person or on the same side of the family? And basically, has anyone in your family been tested for this gene? Or have you even been tested? Because we have patients that come through with a history of breast cancer. And I'll show you, this is the form that every breast center patient that comes through the Memorial Hermann system fills out. I don't know if you can see it very well, but it's just briefly, the top box is basically identifiers. Where was your last mammogram? When was it? And your previous ultrasound. Have you, what age was your first pregnancy? What are your medications? First menstrual cycle. The middle section of our form is current symptoms. Basically, are you having any pain, palpable nipple discharge? Have you had any surgery? If you've had surgery, what did you have? Have you had cancer? If so, how was it treated? In the final 2 lines, we ask, do you have a family history of breast cancer? If yes, check. And we have mother, sister, grandmother, other, and then we say age, diagnosis. And then we ask the same question for ovarian. So, and then the bottom half of the form is really more for the tech to mark scars, moles, write anything the patient says that the doctor might need when interpreting the films. So, looking at our form, these are the things we're not asking, or actually not asking clearly. We really don't emphasize both maternal and paternal lines of breast cancer and ovarian history are important. We don't even ask if they're Ashkenazi Jewish descent. We don't ask about male breast cancer, or you could write it in, but we're not specifically asking that. We don't ask about pancreatic, or as you'll see later in the updated prostate cancer family history, and we're not asking if anyone's been tested for the BRCA genes. So this was our first form that we decided to use, and we basically, if you look, asked those questions that I said before. We thought, well, let's just go straight to the point. And the point of some of this talk is that things in committee and everyone looking at them look pretty good, and then you roll it out, and when it goes into actual patients filling this out, or you put it into into working form, you realize that not everything is working so well. So as far as what we asked basically, have you had breast cancer or family history under 50? Is there anyone had cancer in both breasts? Is there any ovarian history at any age? Are you Ashkenazi Jewish? We asked 2 family members have the same type of cancer. This turns out to be a very bad question. You get all sorts of answers on all sorts of different cancers. And the genetic counselor kind of wanted that in the beginning because she was also saying, well, there's a colon cancer gene, there's all these other genes. But for our practice, it was kind of a quagmire for a breast cancer only practice. We asked, do you have a relative with male breast cancer? And then has anyone been tested? So the problems with the first form, this really was more personal. Everything was lumped. Personal and the family history were lumped together. We really didn't have enough room for the patients to write the specifics because some people have a very extensive history or lots of other things going on. And it wasn't that easy to interpret for when the doctors tried to look through. It wasn't quick as we're trying to do our mammograms and everything and be efficient. It took a lot of time to analyze these forms. We didn't really emphasize maternal and paternal lines. We didn't ask the triple negative question, and we didn't ask about pancreatic cancer at the time. So second attempt at our form. And you can see that we kind of separated personal and family history a little better. It's a little easier for the doctor to quickly glance at it and read, but it still wasn't good in practice, and this is why. It generally was just too long and still confusing for our patients. Our patients are from many different backgrounds and ethnicities. English is not the first language of a majority of probably of our patients at Southwest Memorial. We still really didn't stress that maternal and paternal lines, and I don't think actually, in the community, just breast cancer in general is starting to emphasize the paternal lines, but I think a lot of everything was maternal 10 and 20 years ago. People are still left with that in their head. And there still was not enough room to write, and these were very messy papers. So before I tell you what our final form, I kind of want to, at this point, the guidelines have changed. And these are the most current guidelines that started in April. And talking to my genetic counselor, actually a lot of places still haven't really adapted that much. And unfortunately, a lot of insurance companies haven't still authorized, aren't following these guidelines. But I want you guys to know how they've changed. And if you can see it's even busier now, but I'm going to distill it down on the next slide. You can read this on your own, but for sake of clarity, the next slide shows how they basically changed from the 2012. So basically, they've added aggressive prostate cancer as a risk factor for the BRCA gene, and they specifically state it has to be greater than or equal to a 7 Gleason score. And this is going to be a big problem because who knows what their dad's, grandfather's, uncle's Gleason score was. I don't know how you're going to ask this question. The Myriad genetic counselor said people are using really more a young age diagnosis with breast cancer, or did someone die of prostate cancer, or did someone die of prostate cancer is a sense of, is it an aggressive? If you have an 88-year-old grandfather that was diagnosed with prostate cancer, probably not going to be something you should pay attention to. So the guidelines have changed that if you have a personal history of breast cancer or greater than or equal to 2 close relatives with pancreatic or prostate, you should test. If you're a patient with prostate or pancreatic, which this would be male patients, more obviously, with greater than 2 close relatives with either breast, ovarian, pancreas, or another aggressive prostate, you should test. Now it's been easier. They've lowered the recommendations for testing with breast cancer history. If you were diagnosed with breast cancer at any age and have only need now 1 close relative who is diagnosed under 50, you used to need 1 under 50 and 1 extra. Now you don't. You only need 1 under 50 to be recommended for testing. Same with if you were diagnosed at any age with breast cancer, now you only need 1 relative with ovarian, and you should be recommended for testing. And if you go back to the previous slide, you'll see the clinical judgment section to test has been really expanded, giving a lot more leeway into the physicians and the genetic counselors using this family history to recommend testing. And what my genetic counselor said is that the insurance companies aren't quite buying that still as much. They're pretty strict on some of these genetic insurance companies with approving it. The other interesting thing coming down the pike regarding to this is that the new Affordable Care Act recommends paying for genetic counseling. My update on that is that they haven't released the recommendations yet. They think they're going to use the U.S. Preventive Services guidelines. According to her, they have a draft, and it's all up for comment among the geneticists right now. So it's expected to be released, and they're expecting that the Affordable Care Act will use those guidelines. So that is something to look out for in the near future. So now that we've addressed that, this is the present form we're using, and we are still going to need to modify it again. But basically, it's been working pretty well. It's pretty easy to quickly glance through if you're the doctor. We still separate the personal from the family. We have a little bit more room to write. Our genetic counselor liked the premenopausal word because she thinks that captures more patients, because you could be 55 but still having your period. And if you got breast cancer, you really should qualify for testing. However, we realized that in our patient population, not many people know what this is. And they've been filling out yes on the previous form and putting their age down, and then no on this form. So we're going to change it back to -50 age. We also, in the family history, haven't asked the prostate yet. Going to have to deal with how we're going to word that. That's going to probably end up being a little confusing. We do ask if they have hereditary cancer. It's too vague. I get a lot of yeses and negatives, and I don't know who tested. Was it the patient? Was it an aunt? And sometimes they're filling it out. They're colon cancer patients, and they'll write that in. We have colon cancer in my family or something, so we need to specify that. And the final question is a very bad question for us. It's, are you interested in genetic counseling? And what we've seen, the genetic counselor thought that was a good thing to add. However, what we tend to see is that someone will answer no, 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 like a little 80-year-old worrier, and then circle yes, she wants to talk to a genetic counselor. And that's kind of not using our nurse navigator's time and everyone's time efficiently. And a lot of people might fill this out, yes, 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 I mean just remarkable history, but circle no on this. And we're basically not paying attention to them anyway. We're still going to contact them and let them know we think they're high risk and what we could offer them. So we're going to take that question out on the next form. So going through all that, now what do? Now that we have our form, we try to identify these patients. I'm basically going to talk about my clinic and how we went through the process of implementing these forms. And you can see if some of this works for you. So the issues you have once you want to identify these forms is who in your clinic goes over this form or answers questions with this form on the patient. How do you train your personnel about this subject? Who is the person that goes through the actual form and decides who's going to need recommendation for counseling? Who contacts the patient once you've identified these patients? Who does the testing? Who knows about all these insurance issues? Who does the follow-ups for results? And how do you inform your referring MDs? So I will say Myriad Genetics was very helpful in getting this discussion and helping us. So they actually did this fancy slide for me. And this is basically how Southwest Memorial works. It's very similar, I think, to most breast clinics. Patient comes in, they register, they fill out a bunch of forms, they go to a waiting room, and then depending on their tests, whether it's a screening mammogram, a diagnostic, or an ultrasound, a tech brings them in, goes over the forms with them, performs a study, it's a screening mammogram, reads it, the radiologist reads it later. If it's a diagnostic mammogram, the doctor and tech look at it immediately and have an opportunity at that point to talk to the patient. On ultrasound at our center, we have ultrasound techs that see the patient, and the doctor comes in and completely also double checks the patient. We do whole breast ultrasound. There's a lot of FaceTime with the patient from the doctor and the tech within this study. But basically, the doctor does a report, the patient leaves, the reports go out to the doctors, and a letter gets generated. We use a PenRab reporting system at Memorial Hermann. So going step by step, who goes over the form with the patient? The front desk, your techs, your nurse or nurse navigator, the doctor. And at Southwest, we decided that everyone has access to this form and can hit the patient or go over this form with the patient as they're going through. So just to let you know our kind of process, Myriad recommended this process to us. They, in their experience, they think once the patient leaves your breast center, they don't come back for genetic testing. You've lost them. And in their experience with rolling this out on other breast centers, they think you should capture the patient as best you can while they're there. And they recommended this to us as we go through it. Basically, it was that our techs, that our front desk kind of looks at it closely, might red flag it. Our techs had a lot more say, and would look at this form, would discuss, would make the decision that the patient has enough indications that they might need genetic testing, and would red flag it, perform the test, and I guess while the patient is still in the clinic, she would go get a brochure and maybe watch a video. Then either the doctor or the nurse navigator would come approach the patient in clinic, discuss it more. The patient would decide right then if she wanted testing, and someone, a tech or a doctor or the nurse, would draw the sample and send it off. Patients that decided they want to think about it or whatever could make a follow-up appointment in a week. And then once they drew the sample, there'd be a follow-up appointment scheduled. So that's what they recommended. I will say we had, that didn't work for us. And I went over this earlier. What we thought for our out of extensive discussion with everyone involved, especially my radiology group, is this topic is just a little too complex for everyone, doctors and employees. We thought our clinic is too big and too busy for this process. We actually have a core group of doctors rotating through reading our study or doing our work. But there's a lot of them that are rotating through. There's different vacations, different days off. We thought that it was just too complex. We also thought the referring doctor should have really a lot more say into this than that workflow provided. Also, we have trouble just with insurance getting a screening mammogram approved, or a diagnostic mammogram can be a total quagmire. We really didn't want to get into this with genetic testing. And we also thought that results discussion was one extensive, maybe over a head, although they said you can easily be trained to do this. We thought we didn't really have time, and we had some serious consistency issues with our scheduling, and we did not want patients to feel shuttled through or dropped or fall. So we elected not to do that process. So then we decided, well, who would do the testing? Should we train one of us to be the head person? Should we hire a genetic counselor? Should we train our nurse navigator or a PA or a clinical nurse specialist to do this? We had extensive discussions in our group of Houston Breast Imaging, and a majority of my colleagues did not feel comfortable with the radiologist doing the testing. It was basically down to the same things: our time, our knowledge, the logistics of it. We thought that we were kind of overstepping our bounds, or it was out of our realm of expertise. Although there are plenty of there are some breast centers in the country that the radiologist does do this. So this is what we decided to do initially. The patient, we added the forms. They filled them out. The radiologist was the one that went over the form and flagged them for genetic counseling. In ours, we're not paperless yet. We're trying to get there, but right now we have a little stamp, like a callback stamp. We stamp the chart, we put it in a separate pile. The nurse navigator in our clinic was selected to be the point person. She picks up these charts, she calls the patients by phone. The ones she could contact, there's an issue with actually getting a hold of these patients, but she could schedule them. And when we rolled it out, we had contracted with an off-site genetic counselor downtown in the Med Center in Houston. And these were our results from that. And there's really only 2 months, because to be quite honest, we were in negotiations, contract negotiations, to get this genetic counselor to come to Southwest. But we decided, let's try the form, let's roll it out, let's pilot it like this. And this is what happened. We identified in a little over 2 months 155 patients that we thought might be high risk. Of those, only 6% made appointments to go downtown. Of those, only 3 went downtown. And of the 3, only 1 was recommended for testing, who tested and she was negative. So Myriad was actually right. Once they leave your clinic, it is very hard for getting these patients back. They have busy lives. They tend to be on the younger side with kids and working and jobs, and doesn't work so well. So, this is what we currently do. Basically the same stuff. We have the risk. We have texts that go over the form when they see the patient. If they see questions, any questions, we don't overtrain our tech. Any of the questions on that sheet are positive. They have a script to say that we're going to look at this, and you may need, we may recommend you for genetic counseling. The radiologist still red flags them. The nurse navigator still is a point person. But now we have a genetic counselor that comes on Wednesdays and Fridays. We've tried, if we have a patient that we see in clinic and our and our genetic counselor is on site, we try to see if the patient wants to see her right then. And we've had that work a handful of times. And it is great. And our genetic counselor does all the pre and post counseling, performs the tests, submits the paperwork to Myriad. Now there'll be more companies operating this because of the Supreme Court ruling. You cannot have a patent on a human gene. So Myriad's not going to be the only player now. And she knows all about insurance. I am the supervising MD on the paperwork. Okay. So genetic counseling issues, why we decided on this and how it works. So we did have Myriad. It's very helpful. They have a lot of knowledge on training personnel about the tests and the syndromes. And they have scripts they've used in many different clinics. And they ended up coming and training our techs at a routine quarterly meeting. They're actually going to retrain. It's been a year. We need another little session. We decided our doctors are the best ones to interpret these forms. They come back more complicated than you think, written by these patients. There's a lot of subtleties, as you can see by that giant family history paragraph on the NCCN guidelines. There's a lot of, it's not as cut and dry as you think it would be. And our nurse navigator is working great for us as being the contact person. She's keeping a database, she's following up with patients, and she's got a good working relationship with her genetic counselor. We actually try to make things pretty easy. We try to kind of alleviate as many hurdles as we could to scheduling with a genetic counselor. So we built this genetic counseling appointment into the Memorial Hermann software. So you can schedule a mammogram or a genetic counselor or an ultrasound or anything you want when you call into our 1-800 number. We decided instead of dealing with insurance at this stage, we're not really billing. We decided to cover our charge. Memorial Hermann is paying for the genetics time, and to kind of cover some of that cost, we are charging the patients $50. We thought that wasn't exorbitant. Most of our patients could afford that. We do obviously dismiss it if they can't even afford that, but it seems to be working. This is also going to be changing now with the new Affordable Care Act and the insurance requiring, covering these costs more and stuff. So we're in present situation. We're looking at other billing options or other reasons to do it. But this is how we're doing it now. And why we chose a genetic counselor. Basically, we all agreed that they have the time to take these patients and the knowledge to answer a lot of their questions that might come up. They really have access to that computer-based risk models, the Tyler Cusick, that we don't, to really answer not only if they need genetic counseling, but maybe they don't satisfy the NCCN guidelines, but they have enough family history that they are still high risk and need a screening MRI yearly. That's valuable information that we don't have right now at our clinic. They can schedule the appointments and give a phone call or an appointment result appointment. They can look for other genetic symptoms. There's some syndromes. There's some very rare syndromes I didn't cover, but there's other genetic tests out there that they could flag. Discussing this with the patient that we thought we would not flag if we did it another way. This insurance company process is getting ridiculous. They know the paperwork. They can fill it out. And basically, we live in Houston, Texas, so we were kind of blessed with a giant city, and we had access to one. We can find one. People that are practicing in small towns are going to have a problem with this, and you might have to, work with better training a motivated staff member. Just as an aside, recently, last week, Cigna announced that they will no longer allow BRCA testing from anyone but a genetic counselor. The doctors are all up in arms. Doctors cannot take a test. Oncologists, breast surgeons, they have to go through genetic counselor. So if you have patients that you don't have this set up yet or you don't have access, you actually can come to Southwest. We're happy for you to schedule to meet with our counselor and on your Cigna patients. So finally, our results. So in general, our referring physicians love this service. It takes something off their plate too. It is a complex subject. Not all doctors feel well versed in it, and if they can refer something out and know that we're going to handle it and close the loop and get back to them, they like it. We have plenty of our oncologists, our primary care doctors, our OB-GYNs, and our breast surgeon that are using our genetic counselor. I mean, some of them, don't need a mammogram anymore or whatever because they've had a bilateral mastectomy or anything, or for whatever reason, and they're just straightly scheduling, and we're happy to have her used. We actually had to expand her days in clinic because our wait times were getting too long to see her. And now Memorial Hermann is in discussion to maybe hiring a full-time geneticist in the Memorial Hermann system and rolling this out system-wide. Specifically, our statistics. So this is current to this week. We started in August last year. We have identified 611 patients on our form that we thought might need counseling. Of those, 148 appointments were made, which is 24%, which is up from 6% from when we had them off-site. And then of that, about half showed up for their appointment, 75, which is up from 30% when it was off-site. Wait, did I skip? No, okay. So of the patients, we had 75 that showed up for appointments. Of those, 48 were recommended for testing. That's about 2/3. And of those, 2/3 decided to test, which is 32. We've had 28 negatives, 3 positives, 1 positive variant, and a third, 16 weren't run. The reason they weren't run are insurance issues. They didn't meet the strict NCCN guidelines, or the cost was prohibitive. And how this works is the genetic counselor goes through all this with the patient, decides that she thinks they should be tested. The patient says, I want to be tested. They get swabbed, buccal swab, and then it gets sent to Myriad. Myriad holds it. And insurance clearance goes through, and all this other stuff goes through. And then they get a phone call. What's their deductible? Does insurance prove it? And Myriad has all these payment programs that they'll tell you that really they bend over backwards to make it affordable, although it is a $3,000 test. So patients find out that, oh, you owe $1,000 in a deductible, or even a lot of patients can't afford a payment program on $3,000 even. So lots of people can't afford that. So it's still cost prohibitive. Hopefully, I'm optimistic these costs will come down. So the other thing is what we're working on right now to strengthen our process is the patients that came through and are flagged by our geneticist to be high risk for screening MRI. Presently, she tells the patient her results and gives the results to the referring physician, and they're pretty much in charge of scheduling these tests. What we want to do is tighten up our database, or tighten up our system, and actually have us help remind the patients when their testing is due, schedule their MRI, give better letters and follow-up processes in this. We ultimately think that if we have a high enough volume of high-risk patients, we could start a high-risk clinic. We could partner with a clinician or a PA associated with a clinician or something and provide a one-stop shop to our high-risk patients who can, very anxiety area. So we could provide something where they could get their tests in a more timely manner. They could get them all at once, or they could have a point person to help them if things are positive and what to do next and things like that. So in conclusion, every breast clinic is different. Our model will not work for everyone. I mainly wanted to show you how the fluid process that we have gone through, how much things have changed since we started. We're still changing and tweaking it. The main issue I wanted to get across is, are you asking the right questions in your practice to find your high-risk patients? If you are, congratulations. I think you're providing comprehensive breast care. If you're not, could you use anything I just talked about to help detecting and communicating high-risk factors to your patients and your MDs? So thank you.
That was great. Looks like we have some questions already coming
All
in.
right, let's see.
One is Signal no longer is covering the BR or the bracket testing being offered in MD offices. How are your visits reimbursed? Which I think you may have
So I
touched
kind of,
on.
that might have been an early question. So
Yeah.
we're still, although I will say this week, of course, as I'm getting this talk, we still are charging the $50 for our genetics time. I do think we ultimately, Marriott was very helpful, and there's plenty of codes you can use to charge. However, whether insurance actually covers those codes is another thing. I think our genetic counselor works elsewhere at other clinics, and she's found that they're not paying for some of these codes. We'll see, as we said, how things change and how these new recommendations come down the pike. Because supposedly genetic counseling should be covered as a screening mammogram and some other things in the Affordable Care Act. So right now it's $50, and she told me this week that she just got the paperwork for Cigna on what they're going to require her to fill out, and she said it was more than she even thought it was going to be. So they are providing some significant obstacles to this. Next question.
Another question, if billing through insurance, does a medical oncologist also need to see the patient in addition to the genetic counselor?
No, apparently not.
Okay, and now I'm going to unmute the phone.
All callers are muted.
And I want to mention too
All callers are unmuted.
that you do have some people on the line that are from Memorial.
Yeah,
Sloan
see, Fania is my breast manager, center
Oh,
manager.
great.
So she's on the line after this talk, and she can answer some of the specific, because I'm kind of the ivory tower doctor and really doesn't know a lot about billing or any of the logistics of this compared to her.
Any questions on the phone or any additional questions online?
And I wanted to say, just for people out there, the easiest way to do this, and what I'm kind of gunning for now that we've gone over this, is the tablet-based history intake forms are out there. Are going to be much easier than this form. Penred, the updated Penred software, which I don't have right now, but I'm going to be asking for, has this tremendous tablet that basically runs BRCA Pro and Tyler Kuzik and gives you your numbers right there as they're filling out. So really would help capture these patients and be less fiddle factor. I mean, the doctors have, it comes out red with the numbers right in front of you as you're on your first screen as you're reading the mammogram, and that would really make people paperless. And but there's a cost, of course, to that, and there's extensive computer and IT integration, and nothing is easy at these big institutions to get those approved and budgeted and rolled out. So that's another way if you're in a smaller or clinic, or if you're looking for a new EMR program, I would recommend really looking into that, because there's a lot of good software out there that can handle some of these high-risk questions and not make them very easy for the patient to fill out.
Someone asked if they could get a copy of the presentation. It is available on the left side of the screen under Files 2. You can download it, but also the whole presentation is recorded and will be available on our website next week. That's bhctexas.org, so you can view it all over again or share it. Are there any questions on the phone or any additional questions online?
This was great.
Oh, great. I'm glad this was, I don't like to talk. So anyway, I'm glad that this came across well. I worked hard on it, but it actually, it was good that I gave this, because it actually made me review everything, because you kind of get in a mode where everything's working while I've set the apple cart, but I actually realized that we still need to modify this, plenty of modifications that we need to do, and mainly we need to streamline this from my nurse navigator. She is taking a lot of time on this, and we need to tweak it a little bit to get her off the phone so much with these patients. So we'll see how we can improve it. There's always room for improvement.
Can I ask one question? Do you think a lot of the hesitancy on taking the test is really just, a lot of people worry that they've got all this information out there, about their health, and they feel like, I think a lot of people feel that it will hurt them down the road.
Right, and what we say is, and actually it was a national law that got passed in 1996, it is illegal to deny coverage on anyone based on a genetic test. But that really hasn't gone out to the mainstream. A lot of people think that, oh, if they find out I'm at high risk, they're going to drop me from insurance, which now you can't do. But anyway, but there's a lot of, oh, what do I do? There's a lot of stick your head in the sand type mentality. I don't want to know. I don't want to deal with this. So there's all different barriers to getting through to patients on why. The main thing that I think works is how screening recommendations totally are different on these patients than what you read on the women's magazines and stuff like that. We're already having issues with 40 to 50 and annual biannual. I mean, there's so much controversy surrounding this. It's just too confusing. We have a very mixed messages going out there on screening, but I think in these high-risk patients, if you can get one-on-one with them, you can explain how things would change if you had this knowledge. We would do things very differently with you and your daughters and your granddaughters. And, I tend to, when I see the older patients, they're like, well, I've had my kids, I'm old or whatever. When you explain to them how it would affect their granddaughters, their grandsons, this can be handed on by men. They don't understand that. They're like, oh, I only have boys. I'm like, well, you could have given this gene to your boys who have given it to their girls. And then they're like, oh, there's a lot of light bulbs that go on when you try to explain how this gene is handed down and how it comes from men or females. If you're a mother of all boys, that doesn't mean you shouldn't be tested. Or even if you're a nun, your aunts or, your nieces and nephews and other people might need to know this. And they might not get covered, because you decided you're the person that should be tested. And if you don't want to be tested, they might not get covered trying to be tested. So there's lots of difficult things that come up, but worth the time.
Okay, well, thank you, Dr.
Thank you.
Kushwaha. That was a very informative presentation. We'd also like to thank our program committee for organizing the webinars. It's chaired by Laura Pena with Harris Health Systems, and the committee members include Gina Lawson with BCCS and Lizette Martinez and Yesenia Moore, also with Harris Health System. Our next free webinar will be Thursday, December 5th. This is the Thursday after Thanksgiving at noon on navigating patient navigation, and will be presented by the Breast and Cervical Cancer Services Program staff. Registration is open. You can register online at www.bhctx.org. Lynn would like to make an announcement about our 9th Annual Breast Health Summit. Registration is open, and we encourage everyone and anyone interested to register. It's going to be fantastic this year. We're at a new venue, and again, that registration is available through our website, bhctx.org. Thank you, everyone, for your time, participation, and attendance. Have a wonderful day.